Following a diverticulitis, this huge abscedation could be treated conservatively by drainage, as well as this abscedation in figure 2 following a nephrectomy after some weeks. This thickening of the wall in figure 3 was due to non-neoplastic reasons. In figure 4 you can see both free gas as a sign of perforation as well as gas captured in the lung left. An asymptomatic aneurysm of the hepatic artery had to be noted here in figure 5. It was called. An impressive co-inflammation could be noted here in figure 6. Two different stages of these lithogenic inflammations can be seen in figures 7 and 8 according to the stage of treatment and leading to cholecystectomy in both these cases in the end. In this figure 9 one finds vividly perfused gallbladder wall varices. This biductal stenosis in figure 10 shows from the very beginning the need for the double stenting, and this was of course controlled as well by ultrasound. Lower picture. And here in figure 11, a very early duct junction has to be noted, not accessible to US diagnosis. These minor confusions in figure 12 were symptomatic all of them. Flat bulbous as a normal condition is shown in figure 13, containing always some gas and not artificially blown up like in endoscopy. Symptomatic bile duct stones in figure 14. Please note the distended cystic stump. In figure 15, US reveals spondylophytes as reason for the dysphagia. Arteria hepatica is mimicking a colitis in the cirrhosis with hyperperfusion, here shown in figure 16. In case number 17, too strict clipping led in here to jaundice. This case in figure 18 is noteworthy in that gas reflexes in wall structures indicate an emphysematose, which means severe cholecystitis. Repeated vomiting in case figure 19 was caused by gastric outlet obstruction. Like in figure 20, gallbladders in a hepatitis A inflammation have a dyschrenia lacking a gall juice transiently. Typical lymphoma in figure 21 are found in a case of Hodgkin disease. In figure 22 is a typical empyema shown leading to the complaints given. This often in old ladies found carcinoma in figure 23 was already advanced in its stage, as well as this carcinoma in figure 24 with lymph node metastasis already. This carcinoma in figure 25 showed already splenic infiltration, whilst here in figure 26 both a vital and a non-vital echinococosis are shown. CF technology reveals in figure 27 a typical tumor thrombosis. In this case, figure 28, inflammation had led to an urinary bladder leakage. This HCC in figure 29 led to intra-arterial tumor growth. After operation, there was no leakage more. In figure 30, the aneurysma thrombosis was simply left. This gastric involvement in figure 31 was most impressive. In figure 32, dislocation of the PEG was easily proven by ultrasound. In figure 33, fever and weight loss in this young refugee from Africa were significant with ultrasound finding. This figure 34 shows bubbles floating into the liver. In figure 35, you see a perforated diverticulitis. When fine needle puncture was performed in case number 36, a maximum of adrenaline was found in the aspirate. An isolated splenic lymphoma was found in case number 37. This little carcinoma in figure 38 was found at the second glance only. In perfusion study in case number 39, Ormond's disease is hypoperfunded. A long-standing PBC is here shown in figure 40. And in PSC, DH changes are demonstrated as well in figure 41. Consistency in figure 42 is significantly reduced when regarding heartbeat effects against the liver lobe. And in figure 43, deconfiguration of segment 1 is significant for a liver cirrhosis. Fine needle puncture was here in case figure 44 performed. As this symptomatic huge pleurocyst in figure 45 was adjacent to the duodenum, it could successfully be treated by endoscopic incision only. Some gas bubbles remained here after drainage removal in figure 46. This gastric tumor in figure 47 turned out to be a myoma only when it was removed endoscopically. This case in figure 48 we saw only once in a lifetime, a sarcoma of the os pubis. Chronic diarrhea, weight loss, and augmented feeling and motion of small intestinal loops, as here in figure 49, give the diagnosis of a sprue. A case of fatality is shown in figure 50. She died within 2 hours. A double finding in figure 51 as not so seldom, the one unimportant, cystic, but not so the other one, a metastasis. A typical colon carcinoma in figure 52. An incidental finding is shown in figure 53, classed in the end as a lipoma.